Hi, my name is Amy Wingle. Today we will be covering acute kidney injury. Our target population for this lecture is older adults. We're focusing on 65 or older. Pathophysiology of acute kidney injury. Three common classifications include pre-renal. This is the most common and is caused by hypoperfusion. Next is intrarenal, caused by direct damage to the kidneys. Postrenal, this is the least common form, and it's caused by obstruction of the urinary collecting system. Here's a little bit of etiology about acute kidney injury. Our pre-renal failure occurs from volume depletion and blood flow restriction to the kidneys. If managed, no direct damage to the kidneys occurs. Intrarenal, this occurs from direct injury to the kidney tissue as a result of decreased renal blood flow. And lastly is the postrenal, which occurs from any condition that prevents urinary excretion. Here we're going to look at causes of acute kidney injury. For pre-renal, we have hypovolemia, decreased cardiac output, altered vascular resistance, shock, dehydration, and burns. For intrarenal, we have glomerular injury, acute tubular necrosis, interstitial nephritis, trauma, hypokalemia, sepsis, and substance abuse. For postrenal, we have ureteral obstruction, kidney stones, cancer, BPH, tumors, and strictures. Risk factors of acute kidney injury include renal vascular obstruction, shock, dehydration, decreased cardiac output, hypovolemia, sepsis, peripheral vascular resistance, aspirin, and the use of NSAIDs. Acute kidney injury may develop after the administration of ionized contrast media, typically used in like a CT scan. Then we have liver failure, trauma, and surgery. Age also plays a great risk. The glomerular filtration rate declines with age, making it more difficult for the kidneys to compensate in the elderly. This is typically more common in patients who are 65 or older. Prevention of acute kidney injury include adequate hydration, ensuring that you're drinking a minimum of 2 liters of water a day. Stop smoking, maintain a healthy weight, use NSAIDs and other medications with caution, manage diabetes and hypertension, take all antibiotics as prescribed, and ensure that you're treating urinary infections. So here we're going to talk about clinical manifestations. There's 4 phases of acute kidney injury. First is the onset. This phase begins with the onset of the event and ends when oliguria develops. This can last for hours to even days. Oliguria begins when the kidney injury occurs, and then urine output is typically decreased to 100 to 400 milliliters in a 24-hour period with or without diuretics. Can last 1 to 3 weeks. Some of the symptoms or side effects you might see are azotemia, fluid retention, electrolyte imbalances, metabolic acidosis, and dysrhythmias. Constant monitoring of your patient needs to be top priority. The third phase occurs with diuresis. This phase starts when kidneys begin to recover. There will be a dramatic increase in urinary output, and this can last 2 to 6 weeks due to the increase of fluid loss through diuresis. You might see hypotension and electrolyte imbalances in your patient. Again, critical and constant monitoring of your patient is important. And then we have the recovery phase. This phase continues until kidney function is completely restored, and this can take up to a year. Here are some of the assessments. For cardiovascular, we're going to monitor for hypertension, fluid volume overload, dysrhythmias due to hyperkalemia and edema. For respiratory, we're going to monitor for crackles upon auscultation, decreased oxygenation, hypoxia, and shortness of breath. Renal, we're going to watch for low urinary output to excessive urinary output, kind of depending on which phase the patient is in. And then there's a potential for hematuria. Neurologic We're going to watch for lethargy, muscle twitching and seizures. Integumentary, we're going to watch for dry skin and dry mucous membranes. Nursing care for a patient with acute kidney injury include monitoring strict I's and O's. For these patients, we want to do daily weights. We want to ensure we do this at the same time every day in the same manner to ensure that we're getting accurate weights on the patient. We're going to monitor the CVP, blood pressure, and vitals. We're also going to be watching their labs, their BUN, creatinine, electrolytes, and hematocrit. We're going to assess their MAR for any nephrotoxic drugs, including NSAIDs, aspirin use. Any of that needs to be noted in the patient's chart. Assess for edema, restrict fluid intake, monitor diet, monitor ECG for dysrhythmias, provide skincare, and monitor for signs and symptoms of any infection. Here are some of the labs that we're going to look at for acute kidney injury. The serum creatinine will be elevated. The BUN will also be elevated. For the urine-specific gravity, there's going to be an increase during the prerenal phase and then a decrease during intrarenal. For urinalysis, there'll be presence of sediment potentially. Hematocrit will be decreased. Their ABGs will show metabolic acidosis. And then some of the electrolytes that we need to watch closely are sodium. This is going to be increased during the intrarenal phase and then decreased during the prerenal. Potassium will be elevated, our phosphorus will be elevated, and then the patient's calcium will be decreased. For diagnostics of acute kidney injury, we have a renal biopsy. This is done if the cause of the acute kidney injury is unknown. Then there's a KUB. This is an x-ray of the kidney, ureters, and bladder, and this can rule out calculi or hydronephrosis. There's an ultrasound that can detect any type of obstruction. CT scan without contrast is done to see if any anatomical changes, tumors, or other sources of obstruction are noted. Then there's also 2 nuclear medicine tests that can be done. One is a cystography and the other is a retrograde paleography. Here are some of the most common pharmacology that we'll see with acute kidney injury. Administration of IV fluids as a fluid challenge to promote kidney perfusion. The use of diuretics can be used to increase kidney filtration. Calcium channel blockers can be used for patients with nephrotoxicity. Sodium polyestrine sulfonate helps remove excess potassium. Sorbitol is also used to help remove excess potassium. Sodium bicarbonate, this can treat metabolic acidosis. And then calcium gluconate and calcium chloride can also be used. Insulin, dextrose, and albuterol can be used to help push potassium back into the cells. And then epoetin alpha is used to treat anemia in patients with acute kidney injury. Non-pharmacological care, dialysis through hemodialysis or continuous renal replacement therapy, and then a dietitian should be part of the interprofessional team to help provide a low protein diet, ensure that calories are being met, and fluid restrictions. The patient will need to reduce their potassium, sodium, phosphate, and magnesium, and then there needs to be a discussion of potential use for TPN. Nephrology, these providers will help monitor kidney function and help ensure that the patient's getting the care that they need. Complications associated with acute kidney injury. Older adults at greater risk of acute kidney injury due to comorbidities, polypharmacy, and surgical and medical history. There's also the complication of electrolyte imbalances. Depending on what phase they're in, they can be experiencing hypervolemia or hypovolemia. Again, constant monitoring of those labs and then ensuring that they're getting the proper diets. And then metabolic acidosis. Patient teaching. We want to assess the patient's knowledge and understanding and teach patient according to their learning method. We want to ensure that they really understand what's going on with their body and how they can help manage it. We want to discuss dietary changes, fluid restrictions, and the importance of adhering to these. We want to monitor for signs and symptoms of heart failure, edema, fluid volume deficit or fluid volume excess, and electrolyte imbalances. We want to have strict monitoring of intake and output. They're at a risk for dehydration and orthostatic hypotension. Again, close monitoring of your patient and educating them on signs and symptoms of dehydration and how to manage orthostatic hypotension should that occur. We want to educate the patient on the need to manage underlying health conditions, especially diabetes and hypertension. And here's our references. Thank you for joining today, and that's the end.